Hi, Stark Centeno, and we are live on Facebook right now. Going to be going over today a recent blog I did actually this morning. And, it got hardest things for me to explain to patients is the dramatic difference in training between, let's say, spine or even joint injections and how that training also has to be paired with the concept of which orthobiologic to use in which specific spot. So I'm going to try to share my screen here. In the past, this hasn't worked the best. So you can tell me if it's actually working here. So let's see. Okay, so it looks like we've got it going on there. So this is the blog from this morning. The proper use of interventional orthobiologics requires reading your own MRIs. And so just so everyone understands, what we're going to do is we're going to start with a quick topic, 5 minutes or so, and then we'll get into answering questions, whether it's about this topic or any topic that's on your mind. So starting with this one, really where this came from was this particular case. And this is a patient who came in this last week, and no one really knew what was going on with the neck. This person had seen lots of different physicians, and, it was a good example of how to read your own imaging and how that determines what you're going to do in a patient. So as I walk through it today in the blog, which we'll put in the show notes here so you can read it in more detail, there was loss of the normal curvature here. And you can see this dotted line. That's about the normal curvature for the neck. But you can see this spine goes backwards, actually. And that apex of it going backwards is centered around C3-4. So the next thing you do is you look at C3-4 on the patient's axial imaging, and we see this huge facet over here. This joint is humongous, and so that means it's got arthritis. Not a usual site to see a lot of arthritis. And then we get to the flexion extension x-rays, and we see that there's this big step off between C3 and C4. So C3 is far forward here of C4, and that's a lot of instability. So it's pretty easy to see that this particular patient has a problem at C3-4 in the imaging, which really hadn't been picked up before. Most people were telling him he didn't have a lot going on. And then once you get to the next layer down, you can perform an exam and see whether or not that's really something that needs to be treated. And in this guy, it does. Now, as I went through this whole thing and put this blog through this morning, I came up with these huge lists here. And this is a pretty important thing to understand. I'm not quite sure if that shows it better or this shows it better, but showing you how complex this stuff can get. So this is an example from a knee. So off to the left here, we have all the different stuff that can be injected into a knee that's under that term of orthobiologics. Now, any one of those things over here can be injected in any one of these spots over here. And there's 20 different spots just in this list that things can be injected into. And then if we break out intra-articular as bone and intra-articular, there's another 6 spots over here. So huge variability. So not only do you have to know every single separate procedure, and they're all different, whether they use ultrasound or fluoroscopy to get into all of these spots, you also have to know how to pick the right choice over here to go into the spot over here. So as you might imagine, there's hundreds of thousands of combinations and permutations of all of these. So the likelihood you're going to get the right stuff in the right spot without being able to have some way to pick that spot is pretty small. And then I did the same thing for the low back down here. So you can see all of these things over here, 11 different options that can be injected into 22 or 23 different spots in the low back. Many of those have different levels. So now we're into about 40 different spots. And then some of those have left and right. So now we're into about 80, well, probably 60 different spots. So as you might imagine, just sort of sticking a needle in someone's back is not going to get it done. You've got to identify which spot needs it, what needs to go there, and then know the specific procedure, image-guided procedure, to get that stuff to that spot. So part of that is being able to read your own imaging. Part of that is a good hands-on exam. But it's something that I think most patients don't comprehend, is how complex this stuff can be. They just think, well, I got a neck problem. Someone's going to inject me in my neck, right? How do I know if that person is trained enough to inject that structure I need? As a patient, you really probably wouldn't know that. I know that. I can figure it out in all of 10 seconds after looking at someone's qualifications. But it's critically important to understand those differences, because they're dramatic when we go from this clinic to that clinic to that clinic. And to patients, they're often all but invisible. So I think that's what I have to say about that. If you get a chance, read the blog. The blog this morning on the regenexx.com site will go much more into this topic than I just did. And I think we'll start taking some questions now. So if you've got questions, this is a great time to start writing them in there. Now, it doesn't have to be on this topic. It could be on any topic. And this is really just to get your creative juices going, thinking about this stuff, learning about this stuff, because again, our motto here is an educated patient is a patient that gets better quicker. And we want everyone to get their questions answered, regardless of if they have to do with this topic or something else. So let's start that whole process. Curious to know if you can recommend any clinics for posterior regenerative injections up C1, C2 in Western Canada, Vancouver, Victoria, or Kelowna. Well, I have to say I've never heard of Kelowna, so that one I don't know. When it comes to upper cervical injections, and I think we've had this talk a few different times, they are the rarefied air of interventional spine. So C0, C1, C1, C2 are done frequently by extremely few providers around the world, let alone within the United States, let alone within Canada. So for instance, let's take a big metro area, let's say the LA metro area in the US, where we've probably got, at least 100 or more different fellowship-trained interventional spine physicians. Out of those 100, we probably have one that has injected that or the level above it, 0-1, more than a handful of times in their career. So the answer is it's unlikely that we're going to find someone in Western Canada who has a lot of experience injecting PRP into those upper cervical joints. And I know that's hard to hear, but that's just the reality of that situation. So Regenexx, submitted advance by Adrienne. What is the function of the VDL? How well do MRI or DMX show whether it's injured? Yeah, Adrienne, that's a really good question. Since we got the blog up, let's pull that up. There's a whole blog on that. So if you go to the Regenexx blog, you type in VDL, and it's going to be this one here. A new neck ligament has big implications for CCJ instability patients. So, and there's a nice picture of it here. Now, this is a paper that describes the VDL, and that's called the ventrodural or vertebral dural ligament. I've seen it described both ways. And there's a link here to the research study. And this is a picture from the research study. So what you're looking at here is this is the spinal cord. These are the bones in the back. So this is the back of the skull here. This is the atlas or C1. This is C2. And up in here is this thing called the nuchal ligament. And then down here, the interspinous supraspinous ligament. Now, the VDL has a lot of different structures in different people, but the most common structure is shown. And that is where we've got these fibers now in that ligament that are going sideways instead of up and down. And they're attaching directly into the dura, which is the covering of the spinal cord. The other thing that attaches directly into the dura is the rectus capitis posterior minor muscle and tendon. It also attaches into the vertebral or the ventrodural ligament as well. So the VDL is simply a ligament that's contained within another ligament that attaches directly to the dura. Its function is to pull that dura out of the way or provide some tension in that dura as you move your head around. Now, the rectus capitis posterior minor pulls it out of the way when you're in extension, and the VDL would help it when you're in flexion. So that's what it does. And again, if it's damaged, we're going to see changes in pull on the dura over here. Now, the dura is the covering of the brain, the spinal cord, etc. So hopefully that makes sense. And you may want to read this whole blog. Again, I'll leave that title of the blog up for you so you can go ahead and find that. Jackie, you said if a patient has a CSF leak that was blood patched elsewhere, you would do posterior injection 6 weeks later. Can you explain why that's okay? Time frame, wound inflammation from PRP, hurt a fresh blood patch? I don't remember saying that exactly like that, Jackie. So the first thing to understand is that blood patching is not a science but an art. And what I mean by that is that you first have to know where the CSF is leaking from. So let's kind of back up a little bit and make sure everyone understands what we're talking about. So you've got cerebrospinal fluid that lives in your dura, and that's like a water column in your spine. Now, the most common place that dura could spring a leak is actually in the low back, the lumbosacral area. Then the next most common, thoracic spine, upper back. Next most common, neck. So when it comes to that, that makes sense, right? You got a water column, so there's more pressure on the bottom of the water column, less in the middle, the very least at top. Then when it comes to blood patching just means injecting blood, whole blood, taken out of a vein around that leak. Now, what does a blood patch do? It provides a physical barrier to the leak because the blood coagulates. Now, the problem is the blood doesn't stay there for more than about 2 weeks. It's taken apart by the body over that time. And the other thing a blood patch does is it's got platelets in it, and platelets help to release growth factors that can help the hole in the dura heal. So when it comes to injections after a blood patch, you certainly wouldn't want to disturb anything in that specific area for about 2 weeks. Outside of that, it's not going to have any impact because the patch itself has been cleared by the body, and that little area is either well on its way to healing or not. Then the final thing to know about blood patches is because we often don't know exactly where they are, meaning the imaging of blood of dural leaks is not fantastic, we're generally in a situation where we have to patch a whole area, and that takes time. And regrettably, in insurance-based practices, time is not something that is in great supply. So, for instance, if I'm a provider that's used to doing a new case in the operating room every 15 minutes for interventional spine, maybe 25 minutes on the outset, I don't have enough time to patch the whole lumbar spine. That's going to take me, even someone like myself who's been doing this for 30 some years and who's very fast because I know what I'm doing. I've done thousands. It's going to take me almost an hour, 45 minutes to patch that whole lumbar spine because I've got to do a caudal injection, an S1 transforaminal, sometimes an L5S1, sometimes an L4-5, a 3-4, a 1-2, etc. So about 8 different injections to patch the whole lumbar spine, or to patch the whole 6 to patch the lower thoracic spine, etc. So just be careful there, because patched means that someone did that. And unless they did 6 to 9 different injections to patch, they didn't really patch. They just put some blood in one spot and hope for the best. So that's the other thing to know about the concept of blood patching. So submitted advance by Alice. Went to a foot doctor about numbness in feet. Said it was due to lower back damage when a lady rear-ended me. Said laser therapy would not help. So Alice, number one, you got to a really good foot doctor, because most foot doctors who see that presentation will just claim it has something to do with something in the foot, right? They know the feet. So that's a great foot doctor. If you have any other foot problems, I'd go back there, because this guy knows what he's talking about. And what he's talking about is it's very common if you've got chronic back issues to have a pinched nerve in your low back or an irritated nerve in your low back that causes numbness in the feet. So the fact that he identified that is tremendous. I will give him huge kudos for that. Very good doctor. Write that guy's name down. Now, what do you do for something like that? Well, you've got to figure out what's causing that. That can be a herniated disc, a bulging disc, instability at that level, stenosis, which is too much bone. So after the MRI, each one of those things, obviously, and the physical exam and the history, each one of those things has a different treatment for it. All of them, in general, have orthobiologic solutions. So let's say it's a herniated disc, and you just had a car crash 2 weeks ago. Then a platelet lysate epidural would be the way to go. Let's say it's a central canal stenosis at L5S1. Then that's a completely different procedure. It's still platelet-based, but we're injecting totally different structures. We're injecting the ligament and flavum, probably the facets at that level, probably epidural at that level, and the ligaments at that level. And we're injecting different things into each one of those structures. So great provider, write that guy's name down, super honest dude. So I'm going to give him a thumbs up for that diagnosis, because that's not a common one you see when you go see the foot guy. Jackie, what can Regenexx PRP Epidural do for herniated disc? Regenexx website doesn't fully explain it. Will improvement of Regenexx PRP Epidural for herniated disc show up on repeat MRI post PRP Epidural? So Jackie, if we're talking about a herniated disc, now remember that's very different than a bulging disc. So two completely different animals. But if we're talking about a herniated disc, which is where the stuff inside the disc has squirted out, then the focus of, and really would be a platelet lysate epidural, would be to improve the blood supply in that area and to ramp up the body's ability to clear away the herniated disc material. Meaning that if we leave that there long enough, in general, what will happen in most people is that over a year to 2, somewhere in that time frame, your body will get macrophages in there, which are the body's garbage men, and they will break down the disc structure and haul it away. The goal of a platelet lysate epidural is to make that process faster and also provide some relief during that time without injecting toxic high-dose corticosteroid in that area. Meaning if we can always inject high-dose steroids, but that's not going to increase the breakdown of that area. It will cause anti-inflammation, but it's going to actually hurt the cellular activity there, which is not what we want to do, right? We want lots of macrophages coming in there and taking that stuff away as quickly as possible. Pia, is the clinic in London able to do posterior C1, C2 injections with stem cell PRP? I don't have a good read on that one. Like I said, we're talking about very few people that have done a lot of those. So you're going to have to ask them the following question. Do they do that on a regular basis? Meaning, regular basis for a doctor is do that 20 to 40 times a year. And you'll have to ask them that question. I don't know the answer to that question for them. So if they're telling you, yes, we do that 20 to 40 times a year, then I think that's something you can try for sure. If they're telling you, no, I've only done it 10 times in my whole career and we only do it a few times a year, then the experience level isn't there. But that's a question you'll have to ask those guys directly, because again, these are not common procedures for even advanced interventional spine physicians to perform. Hence, the experience is not there. And why would it matter? It matters because we have the vertebral artery there that goes and supplies blood to the back of your brain and cerebellum. So at the end of the day, getting into that artery and not recognizing that you're in that artery, which requires a digital subtraction angiography package on your fluoro machine, which is not usually found on spine fluoro machines because it's usually only bought and paid for, it's expensive, on interventional cardiology machines. It requires that and the ability to run what's called a DSA loop to make sure you're not injecting in the vertebral artery. Why? If you inject into the vertebral artery with something that could cause a clot, that's a posterior circulation stroke and a bad day for everyone. Obviously worse for you than the doctor, but it's also a bad day for the doctor too. So that's what we're talking about here. So incredibly important to get that information. Number one, are they doing this 20 to 40 times a year? Number two, do they have a digital subtraction angiography package on that fluoro machine? Those are the two things to know. Regenexx Harry Winston, would you advise patients in the UK to try Echocells for posterior injection and see if that helps CCI before traveling to Colorado? Harry, you can certainly try posterior injections and see how that goes. I think there's not a lot of downside there if we're talking about simple ligament injections and injecting, PRP or platelet lysate prolo into those supraspinous, interspinous ligaments all the way up and down. When it comes to injecting the upper cervical facets with something like PRP, I just talked about that one up there. And let me, since this seems to be one that keeps coming up, let's try to pull up a blog here that goes into more detail that everyone who is interested on that topic can read. So let's get into that a little bit. Since we have the blog up, might as well do that. Let's see. I may have to peruse around here to try to find the right blog on this topic. Just because I got a lot of blogs here. Well, this one might be a reasonable one to get into that a little bit. Yeah, probably not the right one. Well, guys, I don't want to waste your time trying to find this particular blog just because, but I will try to see if I can look it up and have Carol put it in the show notes so that you guys can read about that in more detail. Roger, this is why so many patients have had to read their own MRIs. I had to. My neurologist in North Vancouver said he didn't need to look at the images. He trusted the radiologist's report, which missed three things: right alar mostly missing, skull shifted to the right, and compressed left jugular vein. Since MRI DICOM files and Regenexx was used to justify my PSEL operation in September 2020. Thanks for pointing out where doctors need to read imaging. You guys are the best. Well, thank you, Roger. Yeah, so again, as I put in the blog this morning, and I think this is super duper critical for everyone to understand. When a doctor tells you, I trust the radiologist, you need to run. Well, because number one, if we're talking about a fracture, obviously you can trust the radiologist. That's what they're used to looking for. If we're talking about something big like a herniated disc that might require surgery, you can trust the radiologist. But when it comes to finding these other things that drive where orthobiologics precisely need to be placed, we can't trust the radiologist, or certainly not 99.9% of them, because they're not going to read that stuff. And so the doctor has to read his own or your own films in front of you and show you where those issues are and why, or just find another doctor. It's that simple. Because I trust the radiologist is really code for, I don't really know how to read that MRI. I don't have the time to do it. I never really learned how to do that. And, get out of my office. I mean, I'm sorry, but that's what that means as a doctor. I don't want to be bothered to take the time to learn how to read those films because it's just not that important to what I do on a day-to-day basis. So that's obviously not where you want to be. Elizabeth, hi, Dr. Centeno. This was unrelated to the spine, but are you aware of dental injections utilizing PRP? And if so, who those dentists might be specifically for a front tooth injury where the EDA is showing an inflamed ligament around the tooth? Elizabeth, that is a great question. Dentists in general were the first to use PRP. So that's, they're certainly going to have experience with doing that kind of work. Now, when it comes to injecting a periodontal ligament, which is kind of what you're talking about there, that I don't know at all. I don't know any specific dentists that will do it at that level. Usually when dentists are using PRP, they're using it to help bone healing or they're using it to help implants and graft. So I don't really have any sense of what to tell you there on that side, but it would be great if dentists did get into things like that, but I don't know of any. Jay, thanks for covering this. In 7 years, I've experienced a lot of difficulty in finding any kind of specialist who would be able to properly identify my neck issues. That said, what kind of specialist would you recommend for someone with CCI to see regularly? Do you have any advice as far as finding specialists who can help both individuals with CCI and who would be getting PICL, PRP? Yeah, Jay, that reminds me of a story that when I was in, let's say I must have been a medical student on a surgery rotation. The general surgeons didn't like the pediatric surgeons in that particular hospital. So the general surgeons had a saying that that your ability to get good care in the NICU was like being in the Sahara Desert. And that was sort of an internal feud. But again, it's the same issue we have here. There aren't a lot of doctors around the country that know much about CCI. You've got a handful of surgeons that focus in this area. And, Dr. Bolognese, Dr. Patel, maybe I can think of 3 others off the top of my head who focus in this area. As far as physicians who are trying to help people avoid surgery, there's not much out there because it's such a niche area. So I wish I could tell you that we had experts out there who I could send you to locally, but it's too niche for me to feel comfortable making that recommendation. There are probably more neurosurgeons specializing in this area, and I make those referrals when they're needed. But when it comes to people trying to help you avoid surgery, that's a harder one to really dive into. Regenexx, Brendan Fuel, my MRI, the radiologist said it was fine. My right internal jugular vein doesn't look fine, and 10 months later, I'm still trying to get them to double check it and give me an updated report. A lot of doctors won't help me because they look at my report and says I'm fine. Yeah, so Brendan, you have to realize that number one, a routine MRI is not going to show the internal jugular vein well. So while you'll see something there that looks like an internal jugular vein, it's highly susceptible to movement artifact. And what I mean by that is since the vein or the artery is pumping or has pulsatile contractions or is moving because if you're a vein, things are being pumped by the heart through you. The problem there is you're not going to get a good look at a vein. So you're going to need to do probably a CT venogram, and in this case, a CT venogram with some motion to try to see if the atlas, which is usually where it happens, is pressing on the internal jugular vein. Now, I wouldn't focus there because that's like focusing on the ornaments on the Christmas tree rather than the branch. And what I mean by that is then you have to ask yourself, why is that happening? And so in a CCI patient, that would be happening because of instability. The fact that there's compression on the internal jugular vein by itself is meaningless. It's just something happening because of instability. So the focus should be getting rid of the instability and thus helping the pressure on the internal jugular vein. So focusing on the branch and not the ornament at the end of the branch. So a very important thing to understand. Brendan, I've seen more than 50 doctors. Actually looked at my MRI also. I had dose PRP in the facets and only medium and the ligaments. Do you recommend any educational material for reading cervical MRIs? So high dose in the joints has to do with the research we've done on mesenchymal stem cells. You can also use high dose PRP in ligaments too. It's just often not needed. Depending on your age will determine what strength of PRP you need where. And then on cervical MRIs, that's a good question. I'm just wondering, so if you look on YouTube, let's go to our channel here. So if you look on YouTube and go to our channel and search under cervical, I want to say I did a video like that, but I can't be sure. So I have to look here because it's probably been years. Well, and we need more specific. Let's go MRI. Yeah, guys, I've done way too many videos through the years. So we do have one on reading a lumbar MRI, which is here, how to find specific nerve roots on a lumbar MRI. But I'm not seeing one that's specifically focused on reading a cervical MRI. So maybe I can do that at some point. But so let's go back to the blog. Pia, you mentioned stenosis equals too much bone. Is that also often the case in vertebral instability where there's canal narrows due to bone formation? Yeah, so Pia, that's what stenosis means, is that there's some extra bone that's putting pressure on either the spinal canal or the foramen where the nerve comes out. And if it's in the spinal canal, it's called central canal stenosis. And if it's in the foramen, it's called foraminal stenosis. Now, there's more to that because oftentimes there are other things that are actively pressing on those nerves outside of just the bone. And really, usually all the bone's doing is making sure there's less room there. So not something specifically to be that concerned about unless that fits with your symptoms and we know what else is causing issues at that level. So Stacy, reading an MRI report is not part of the problem. In my experience, most doctors, even if they do actually look at your imaging and they don't know what to look for, gaslight people with soft tissue injuries because they don't know how to fix the problem. Yeah, so you're right, Stacy. I think that's another issue. And listen, doctors like anyone else, right? They're what's in it for me? Why do I need to learn this? Why should I take this extra time? And the problem is that reading your own imaging takes extra time, right? It's very easy to just pick up the radiologist report and say, yeah. And even that, it's even easier to forget the radiologist report and go right to the conclusions and just read those couple lines, that are numbered at the end, 1, 2, 3, 4. Okay, that's what's wrong. Obviously, that takes a lot more time than reading the imaging yourself and saying, oh, yeah, that's a problem. And over here, it's on that image too. And yeah, that matches what I found in physical exam. So that takes time. So let's see it, guys. I think we're coming to the end of our questions. Usually that's not the end of our questions. So if you've got any more questions, feel free to put them in there, and I'm happy to go ahead and answer those. While I'm at it, and we've got the blog up. So let's see some of my favorite blogs from this last week. I think we talked about the whole Medicare thing. I spent quite a bit of time on that. Another blog for people to consider is just this concept, and I see a lot of this in CCI patients and really neck pain and back pain patients in general. And that is this postural decompensation that occurs. So you may want to read this blog as well, talking about that postural decompensation, some things you can do to help. Now, the stretch that I put in here, this is the easy one. There's a much harder one to do here where me, old man, showed you how to do it. But at the end of the day, just be careful if you try the more advanced stretch here. Okay, it looks like we are winding down on, no, there we go, Damien. Questions here. Your future, will Regenexx create a stem cell formula that will focus on producing increased cells? Yeah, I mean, the problem with that is that that would require different kind of testing than the testing we did to formulate this. So is it potentially possible to do? It is. It's just a much, much bigger project than what we took on a number of years ago when we created the stem cell support formula. Our focus there was to find supplements that would help stem cells in culture do certain tasks better. And that's how we created the stem cell support formula. As far as clinically producing more stem cells in the same patient, that can be done. It's just a much, much bigger deal because then we'd have to give individual supplement ingredients to at least probably several hundred patients, do bone marrow aspirations before and after looking at stem cell counts. So possible to do, but probably a bigger project right now than we want to take on. What are your thoughts about wearing a back brace if you sit at a desk all day to correct posture? Yeah, Jay, I think rather than a back brace, something like a lumbar support where you can increase your curvature in your back here would be a good thing. That can help everything that goes above that as well. And then another thing to think about would be they now have, and they're advertising pretty aggressively for it right now, the little device that you put back here, and it shows you when you're doing this and your posture is bad. It vibrates. It puts an alert on your phone or on your computer. So I think those are probably better strategies than an actual back brace, because the problem with the back brace is it tends to weaken your muscles, and we don't want that. We all need strong muscles. Sherry, is there some kind of special title or letters as an MD would indicate doctor? No, there's there's not. Regrettably, it really, number one, it's a type of practice. You've got to have the type of practice that allows the right time for it. So, for example, during the day, I'll see about 12 patients, maybe 13, sometimes 14. But in a busy orthopedic spine practice, you're required, 20 would be the bare minimum. And usually 30 to 40 is a number that's more likely in clinic. So when you're seeing patients at that rapid pace and succession, you're using a mid-level, usually provider to extend the physician. So that's a nurse practitioner or a physician's assistant. And there just isn't time to sit there with someone and explain what's on their image. There isn't even time to read the image generally, unless it's something very simple. But for complex things, you're just going to read the reports, shuffle through that, and then go on to the next patient. So it's more a type of practice, number one. And then number two, it's someone obviously who has taken the time to learn how to read those films. And that's not trivial. Obviously, it is if you're a radiologist. You read films all day. You're trained to read films. But if you're a non-radiologist, it takes years and years of looking at hundreds and hundreds of films, matching that up to the report, doing additional research on your own so that you can get a sense of what is there. But it's incredibly valuable for what I do because I can say, aha, that's an area I need to treat. And then I can follow that patient up and say, well, did treating that area really move the needle for that person? So that's why it's invaluable, but there's no specific letters, regrettably. Pia, do you believe untreated CCI for too long can put more pressure on the C5-6 area due to different cervical curve due to the CCI? Well, the different cervical curve is not due to the CCI. That's there with the CCI, so it's not due to the CCI. So that's not what's happening there. As far as can CCI put more pressure on 5-6? It's certainly possible that it could, but I think there are probably other things going on, and you need to then treat the 5-6 and the CCI at the same time. Ryan, what should prospective patients be getting in terms of treatment imaging before booking online consult with your team? Yeah, Ryan, I think the biggest thing that we would love to see is that person has at least had a cervical MRI. If you have a DMX or digital motion X-ray, that's a big plus because it then really speeds up the process quite a bit. And then the middle one in there. So I always say it this way: the most likely study that I can look at that's going to determine if you're a candidate and have CCI is a digital motion X-ray or DMX. The next likely study, meaning what that means is lower likelihood of finding it, but still reasonably likely, is an upright MRI with flexion, extension, or movement. And then the least likely thing is a cervical MRI. But if we don't have a cervical MRI, we got to get one because we've got to see structurally what's happening in a bigger picture. So those are the kinds of things we would like to see on someone who is booking an online consult. And then the second thing we're looking for is it likely that person has CCI, or is it likely that their problem is not CCI, in which case I've got to prioritize getting the CCI patients on my schedule. Jay, would you mind linking that device? Let's see here. Let's do a quick Google search. Yeah, that's a good article right here. Talks about, I guess there's a bunch of them out there. These are all little devices like this one here that you put on your body. Yeah, so this is the top one is the one I'm talking about. So it looks like Upright Go is what it's called. So Upright Go is what you want to search on Google. Roger Chin, if I don't need another PICL but still want to treat my knee again with BMC, is a possible switch to another Regenexx clinic closer? Yes, that's definitely possible. That would be a good idea to try to get that done closer. So you can certainly see the local Seattle clinic to get that knee done, and they've got a lot of experience with that. Damon, does a purely vegan diet improve stem cell count versus non-vegan? You know, Damien, I don't think anyone knows the answer to that one, so I don't know the answer to that one. Will your company open another Miami location? You know, that's a good question. That was more a victim, I think, of the pandemic than anything. Dr. Lieber's clinic in Tampa had opened a Miami location. And I think with the pandemic, it just became too costly to keep open. So instead, they expanded out towards Orlando rather than going south. So they may open that again. I don't know. But I do know that was kind of like a lot of things, right? A victim of the pandemic. Ryan, I have DMX but no MRI. Yeah, Ryan. So you can probably then move forward in that, you know, we can see on DMX whether or not you have craniocervical instability. At some point, we'll need to get an MRI, more just to make sure there's nothing crazy that we need to know about. But when it comes to diagnosing CCI, the DMX would be best. So you're probably fine just like that. Adrena, is dynamic supine cervical MRI good enough to check for CCI? Again, when it comes to the likelihood of diagnosis, meaning which study is the most likely for us to get to a CCI diagnosis, it's going to be DMX number 1, upright MRI with movement number 2, or routine MRI number 3. And so DMX most likely to make the diagnosis, upright MRI a bit less likely to make the diagnosis, but still reasonable shot at making a diagnosis. And then regular supine MRI, the least likely to make the diagnosis, but it still may be found. Christopher, any Canadian Regenexx providers? Chris, regrettably, we do not have Canadian Regenexx providers. And a lot of that has to do with the fact that the Canadian government has been pretty strange around orthobiologic procedures. There are now some providers up there. They got shut down from doing most orthobiologics about 2 to 3 years ago. And those providers are now trying to work through Healthcare Canada, I think it's called, in order to try to get reauthorization to do procedures. So Canada, regrettably, has not really welcomed this stuff. Adina, do you plan to open any location in Europe? Adina, we do have European locations on the Regenexx side. When it comes to craniocervical instability, no plans at this juncture to open any clinics in Europe that focus on that area. But when it comes to just Regenexx, we do have clinics in Europe. So if you go on the website, and that's going to be this Regenexx website, and if you just go to the find a doctor here, right there, you can type in where you are here and then find a clinic. There's also a map that we used to have, but I'm not seeing the map right now. Pia, do you have an idea of how much a CX angle reduces upright possible can compared to supine and CCI patients? Yeah, Pia, that's a great point to raise. Let me see if I can show you guys what we're talking about here. I'm probably going to have to stop my screen share for a minute and then reshare. So give me a second to do that so I can explain that better. I just can't expose this patient's name due to HIPAA. So I've got to copy paste it and put it in a presentation to show. And get rid of the patient's name. Okay, so I think we can do this now. Okay, so what we're talking about here, which is pretty critical to understand because I think a lot of the neurosurgeons don't understand this, and that is, in this particular patient, I've drawn this angle to roughly assimilate where this person's neck curve should be. So that's a normal lordosis or neck curve. And you can see that her actual neck kind of goes backwards here, centered at C5-6 down here. So again, it should be a shallow curve going out this way, but instead it's going backwards here, centered at this level 5-6. Now, one of the neurosurgical teams measured this clivo-axial angle and saw 135, which is right at the lower limit of normal for a CXA. The problem is that if you have a lost or reversed lordosis, this angle is going to go artificially down. So this is not a neurosurgical CXA. This is a simple reversal of the normal curve. So as the curve goes backwards, that number of the CXA goes down. So if we were to put a normal curve back in this person, her CXA would go to 145 or 150, which would be totally normal. So very important to realize that there's a relationship, and I'm going to cover this on another video, that there's a hard relationship between this curve and that CXA number. And so you can only measure a CXA in someone who's got a normal curve. Outside of that, it's a red herring because it's going to go down and possibly look abnormal if there's a reverse curve. And the treatment for that is not neurosurgery. The treatment for that is getting the curve back. If that person can have their curve restored, if they can tolerate it. So a very critical thing that you're bringing up here, that there's a relationship between that clivo-axial angle or CXA and the status of the neck curve. If the CXA angle changes significant, is it then basically vertical instability, cranial settling? No. The reason for a clivo-axial angle, which is this one up here, is because the ligaments back here are loose and the head is too far forward this way. So that's a posterior ligament issue back here that's allowing that to happen. And I know this stuff is getting into the weeds here with all these terms, CXA, normal curvature, lordosis, etc. So I apologize if we're getting into the weeds there, but that's an important thing to bring up because I've seen that happen a lot where patients get their CXA measured, they're told it's abnormal, but then when you look at that curve, the CXA is a red herring because it's a reversed curve. So Jackie, if post-PICL AO adjustment makes someone worse, in your opinion, could the vectors have changed? Certainly possible that the vectors have changed. So if you were with someone before who had used a certain set of vectors and that helped, and then you had a PICL and that's not working anymore, then in all likelihood, the vectors have changed. Now, if you've never had an AO adjustment before, then that just may be the wrong vectors, or maybe AO is not the right treatment for you. But yes, if you had them before and the vectors seem to work and then afterwards it doesn't, we have a lot of patients that need to go back to their AO chiropractor and get their vectors remeasured. Adina, can bad neck curve generate low BDI like the CXA case you've just mentioned? Yeah, so the BDI is going to be this measurement of cranial settling. Again, the problem there being that that's going to also change a bit with the curve. And we have to be careful because we need to be able to have a measurement and then a physical exam and then history or other testing that shows that that's causing the problem. Because if we go out there and we just take 100 people off the street and we do MRIs of their necks, we're going to see all sorts of things. We're going to see Chiari malformation, for example. We're going to see low BDIs. We're going to see grab oaks that look abnormal, etc. So an MRI measurement by itself in this field is generally useless until it's combined with other evidence in order to generate a working hypothesis about what's causing the symptoms. And I think that makes patients anxious, because the idea, what patients want to see, and I get it, give me a blood test, doc, that shows me I got this, or give me an MRI number that shows that I got this or not, and then exactly what needs to be done based on that information. But in this area of medicine, regrettably, it's not that simple, and patients get in trouble because they believe it's that simple. And then providers want to make it that simple, but it's not. It's again, someone's history. How did they get this? Someone's response to treatment, their imaging, and an extensive hands-on physical exam. All of that goes into making a diagnosis of symptomatic CCI. So very important to understand that. Pia, how successful is curve restoration? Yeah, Pia, again, it just depends on what we're dealing with. If all we're dealing with is a reverse curve and the symptoms due to that reverse curve, there's some great research published by the Harrisons, who are the guys that started chiropractic biophysics. So those providers can be found at idealspine.com. I'm telling you that because I think that's a very valuable thing to try if you've got a lost curve. And it's highly successful in that group. Now, if you've got someone with CCI and a reverse curve, going to be less successful because some of those CCI patients are not going to tolerate curve restoration until things are stabilized up top. So, but in general, for the right patient, it's a very successful treatment. Okay, guys, so I'm coming up to 2. I think I've got a hard stop here, which I do at 2 o'clock. So any last minute questions, I can answer it all. Okay, guys, so I am going to start winding this down here, and we'll finish with the blog we started with, which is here. So if you go to the regenexx.com blog, you can find this one. It's the most recent one. And again, just to review, it goes over the concept of how critical it is to read your own images, and then how difficult it can be to choose from this long list of stuff that can be injected, and this longer list of specific structures that can be treated, to get the right structures treated to get the right results for that patient. A very critical thing, and one I find that patients don't really understand. They believe that this doctor knows the same exact thing as that doctor, and regrettably, that's generally not the case. For example, this list right here in the knee, this is just the knee. There's probably only 0.2% of U.S. physicians who claim to know how to do this stuff, that know how to do all the procedures to hit all of these structures. Same thing in the back. So here we got the low back. We got this long list off to the right of different structures that can be injected. Probably, again, a fraction of a percent of all providers who are stating that they do orthobiologic spine work know how to put all of this stuff into all of these different spots in the spine, at all of these different levels at that specific side. So again, just it's hard for patients to wrap their brain around. That they don't understand that guy over there doesn't know the same thing as that guy over there, or there might be huge disparate differences in training. Now, one of the things we do at Regenexx is we narrow that training gap so that we've got more providers that know how to do all this stuff, or know how to do most of this stuff. But that doesn't happen in the Wild West out there. And so you can either obviously choose to be seen by a Regenexx provider, where they can, where you've got that much narrower band of what doctors know. And again, as I've said, that doesn't generally apply to CCI, as you'll see on our website, versus having to figure out as a patient, is the guy I'm seeing this guy down here or that guy up there? Because there's a big difference between this guy down here and that guy up there. So anyway, you all have a fantastic weekend. I am headed down to our Grand Cayman site. Thankfully, over 2 years, that's finally opened. And I'll probably be trying to do this down there. I'll have to see what the timing is going to look like and when that's possible. So if I have time over the next 2 weeks, I will try to broadcast from Grand Cayman. If not, then not. But we'll let you know one way or the other. So have a wonderful weekend. And if I am not able to get that done, then I'll see you when I get back in 2 weeks. I would love to tell you it's going to be a great vacation, but it's actually work. So I'm actually seeing patients down there. So it's kind of a workcation or something like that. But anyway, have a great weekend, and thanks all of you for watching. Thank you.